I haven't really told so many people about this, but I was in kindergarten and my hero at the time was my Uncle Rob, and he traveled the world. He was the first person from our family to go to university. So he went to like Miami, Oxford, got his master's at NYU, studied in Cambridge, always had this British accent, was extremely outgoing and friendly and caring. And then he got diagnosed with HIV, and this is early 90s, and then quickly progressed to AIDS. And just remember the marked switch, this friendly, loving, flamboyant, amazing, outgoing guy. And now he's laying on a bed looking like a skeleton of himself. And I remember turning to my grandmother, who was a nurse. I was like, Grandma, I want to fix Uncle Rob. And she goes, well, that's a doctor. I was like, all right, I'm going to be a doctor. I was doing ridiculous things like practicing my signature. But then I learned that there's different types of doctors. And even though I was a kid, I loved kids. So I was like, I want to be a kid doctor. And that stayed consistent all the way through university. Because my wife was a year behind me in university, I stayed around and I was an ER tech. And we took one of our patients down to the morgue, and I opened up a locker, and there was a patient that was an infant that passed away. It was in a little biohazard bag, with his little foot pressed up against the bag. And I was like, I just can't. So I went into medical school, and pediatrics was one of the things that I couldn't emotionally deal with. But then to come full circle, at the end of the second rotation, my preceptor, we didn't see a single patient. She just spent hours telling me why my logic for avoiding pediatrics was flawed. And driving home and praying about this conversation from someone I barely knew. And it was in the middle of this prayer, I was realizing, by avoiding pediatrics because I couldn't emotionally deal with kids dying, I was actually avoiding the patients I care most about, which makes no sense. And then peds oncology got put on my heart instantly. I have to be a part of this to make sure no kids die of cancer or anything related to cancer. 90% of the new cases of pediatric cancer are diagnosing kids that live in low or low middle income countries. But conversely, they only get maybe 10 to 15% of the actual research funds. So there's a lot of gaps that we need to close. Several years ago, they established the first pediatric oncology fellowship training program at Moy University. So Dr. Njuguna and another oncologist, Dr. Gilbert Olmara, were the first two Kenyans to be trained in the first Kenyan pediatric oncology training program. So they're legitimate trailblazers. Festus Njuguna is the senior pediatric oncologist. He's been treating kids with cancer for, I think, almost maybe 15 years now. And because of the relationships that they've been able to establish from being one of the first centers to treat kids with cancer, they're leading the energy and the momentum to really improve pediatric oncology care in Kenya. The oncologist here identified that they want to improve their fever management, and it was just kind of a perfect alignment. I had experience doing fever research in kids with cancer in Michigan, and the oncologists here want to also improve that as well. The majority of evidence on what a fever guideline should look like is based on high-income countries like Europe and the US, and that totally different patient population. One thing is just the difference in deaths from fevers and infections. In the US, it's like maybe 0.5%. Our best estimates in sub-Saharan Africa is 20 to 25 times higher. So the disparity is huge. I started having a lot of conversations with our Kenyan oncologists and pharmacists and nurses and medical officers here, and tweaked and adapted the guideline to make it specific to pediatrics here in Kenya, from the very beginning of what antibiotic you choose to where you decide to stop the antibiotic. And we're just right now about to start a study. We're going to effectively implement that guideline. And there's a lot of excitement because MTRH is really the leading pediatric cancer treatment center in Kenya, but then also expands out broader into the region. We're part of some of the groups that are developing continental fever guidelines because every other center in Africa is faced with these ineffective guidelines that are preventing them from treating patients that they know they should be treating the way they want to. It's really possible that we'd be able to improve infection-related mortality in kids with cancer in Africa, which is currently 10 to 20, 30 times higher than what it is in the US, and, dramatically bring that number down. And we got the blessing of the Antimicrobial Stewardship Committee here and the oncologist. And so I'll keep talking to the people on the wards, and then we'll keep tweaking the guideline.